Good afternoon to everybody. I'd like to welcome all the participants to this particular pep talk. As a reminder, please mute yourself, but always show your video picture. Sign in your name, your Facebook account, or email address in the chat box. Please include names of companions attending with you. Use the chat box to ask questions and make comments while the pep talk is on. There will be group pictures at the start and end of the pep talk, so please show your beautiful faces in the video. Another reminder, please take the online learning evaluation test exercise for mastery of learning and have a perfect score to get a certificate like this one shown on this side. We have placed the link in the chat box already. Another reminder, 50 OLETE certificates, or passing 50 OLETE, gaining 50 certificates will entitle one to a voucher for the free ROJoson telemedical consultation. Another request, please type in your feedback in the chat box during the open forum and before we adjourn. So let's now have a group picture before we start the pep talk proper in 2 minutes. Please show your beautiful faces in the video. Everybody show their faces in the video. Bernie, Semi, Beth, okay, Phoebe, Charlotte, okay, Phoebe Caldino, you want to join us? Phoebe, Gladys, okay. Phoebe, want to join us? Okay. So, okay. Please, okay. Ready? 1, 2, 3. Okay. I have a patient empowerment program which I like to empower the lay people or patients to take control in the management of their health. I started the pep talk on May 15, 2021. That's about 2 years ago, almost 2 years. There are 3 courses in the pep talk. I completed the core course on October 9, 2021. So this shows the content of the core courses. And then from October 23, 2021 onwards, I've been tackling health disorder and health issue courses. This may take 3 years or longer depending on both you and mine, enthusiasm and also perseverance. My pep talk today is entitled Colorectal Cancer Awareness. This is in consonance with the Department of Health Awareness Calendar, which has designated March as a colorectal cancer awareness. Okay. The empowerment objective will be for the lay people to have a basic understanding of the colorectal cancer in their health management. The content for this particular pep talk will be the following: why the awareness month on colorectal cancer? What is a colorectal cancer or CRC? What are the different types? What are the causes and risk factors? What are the symptoms and signs that will lead one to suspect colorectal cancer? How are colorectal cancers diagnosed, both clinically and paraclinically, meaning diagnostic tests? What are the different modalities of treatment? What is the prognosis of colorectal cancers? What are the screening strategies that are being promoted in the Philippines? And then lastly, what will be my advice on colorectal cancers. Let's start with the first topic, why Colorectal Cancer Awareness Month. Okay. So essentially, the goal is to raise awareness on colorectal cancers as a health problem in the community as well as in our personal life. And then to highlight the importance of managing colorectal cancer in the community because one, it is so common. Number two, it's causing a lot of death. And then number three, it is preventable, treatable, and beatable. Okay. So some of the data are given here on the frequency of cancer, why we say it's so common. Colorectal cancer is the third most common overall, both males and females. But in the males, it's the second most common. In the female, it's the third most common. And then among those cancer death overall, it is number 4. Okay. Number 1 is lung cancer. Okay. Cause of death for cancers. Then liver, breast, and colorectal is the 4th most common cause of cancer death in the Philippines. The goals of the awareness program are to decrease in the Philippines the frequency or number of cases. As of now, as of 2020, we have a registry of 17,000 new cases every year. Okay. And then the death, we also want to decrease the number of deaths. As of 2020, there were 6,000 people, Filipinos, dying from colorectal cancer. Okay. The number of people, we also want to decrease the number of Filipinos suffering with poor quality of life, particularly those due to late diagnosis and treatment, wherein extensive complicated surgery with enterostomy or colostomy. So that will decrease the quality of life of this particular patient, especially those with enterostomy and colostomy, chemotherapy, radiation therapy, which may be avoided if these cancers were managed early enough. Okay. So the goal of the awareness program is to decrease the frequency, the death number, and also the number of Filipinos suffering. Okay. What is the colorectal cancer? Essentially, it's a cancer in the colorectal parts of the human body. So what is meant by colorectal? Colorectal includes the colon or the large intestine, plus the rectum and the anus. Okay. So this is the large intestine, okay, or the colon. And then here is the rectum, that is the lower part wherein the feces pass through, going to the outside, rectum and anus. Anus is the puwet, okay? And then rectum is just above it. Then after that, that's the large bowel, large intestine already. Okay. The colorectal cancer can occur in any parts of the colon, rectum, and anus. Okay. So as shown here, the colon has different parts. You have the cecum, ascending colon, transverse colon, transverse means parang, and then you have the descending, pababa, and then sigmoid colon. Okay. So colorectal cancer can occur in any parts of this colon, and also the rectum and the anus. Okay. So sometimes it can extend from one adjacent part to the other. Okay. Example, there might be a cancer in the descending colon extending to the sigmoid colon, or there might be a cancer here in the ascending colon, okay, encroaching on the transverse colon. That is what is meant by may extend to the adjacent parts. But strictly speaking, they're still considered as colon cancers. Or it may be multiple. You can have a cancer in the descending colon. At the same time, you also have a cancer in the transverse colon. So existing simultaneously at the same time. So this is what is meant by being multiple. Okay. Now, what are the different types of colorectal cancer? We can categorize these types into two things, two items, based on the origin or location and extension of the colorectal cancer. As I said, there are different parts of the colon. So if the colon is located here in the ascending colon, then we call it ascending colon cancer. If it's located in the descending colon, then we call it a cancer in the colon cancer in the descending colon. So we specify the name of the origin or location. And sometimes, as I said, it can extend from one part of the colon, from descending colon to the sigmoid colon. Then we just say we just describe that the cancer is extending from the descending colon to the sigmoid colon. So based on the origin and location and extension of the colorectal cancer. Then the other way of classifying the different types will be based on the cell types of origin. So there are different types of cells along the wall of the colorectal. So adenocarcinoma is the most common type in the colon. Then squamous cell carcinoma is another type of cancers. Okay. It's usually located here in the anus. Then other types could be the so-called carcinoid, lymphoma, sarcoma, and others, but these are very rare. Okay. So what's more common will be the adenocarcinoma, which is the most common among the colon cancer, and then squamous cell carcinoma, it's the most common in the anal cancer. What are the causes and risk factors for colorectal cancers? The ultimate cause is a gene mutation that leads to uncontrollable growth of cells in the wall of the colorectum. The gene mutation may be hereditary, meaning coming from the parents, or acquired, meaning not coming from the parents, but sporadic and usually due to environment and lifestyle factors. So between the two, hereditary gene mutation as a cause occurs only in 5 to 10% of cases, whereas the acquired gene mutation or the sporadic due to environment and lifestyle are more common, 90 to 95%. So examples of the hereditary colorectal cancers will be the so-called Lynch syndrome and then the familiar adenomatous polyposis. A word about the difference between the hereditary and familiar cancers, because oftentimes we heard people saying, is this hereditary or is this something else, familiar? Okay. So the two terms are sometimes used interchangeably, but they have different concepts, strictly speaking. When you say hereditary, it's a disease with a known genetic cause. It's coming from your parents. Now, familiar disorders are those which appear to have a genetic or hereditary component. Parang meron kasi maraming family members have it, affecting more family members. Okay, so but the cause for the genetic causation is not known. Yeah, for the meantime, we call it familiar disorder, but maybe upon more investigation, it may turn out to be hereditary. Okay. So if you have a familiar risk, so what are the chances of getting colon cancer with a family history of colon cancer and other cancers? Okay. So a common question being asked. So if you have a familiar risk, a single first degree family members like parent or a brother or sisters with colon or endometrial cancer under age 50, your lifetime risk will increase to 10 to 20%. So tumataas ng konti or mas mataas, no? Compared to somebody without a family history of colon cancer. Okay. So family history is an important indicator not only because of the shared genes, kasi baka pare-pare yung gene ng isang members of the same family, but because of the similar lifestyle in that family. So that's contributed to the maraming kaso ng colorectal cancer in that family. Okay. Acquired or sporadic genetic mutations, which are more common, okay, and these are due to environmental and lifestyle factors. Number one, possible environmental factor will be the viruses. Viruses can also cause colorectal cancer. Lack of regular physical activity, usually when they nag-exercise. A diet low in fruit and vegetable is another risk factor. A low fiber or high fat diet or a diet high in processed meats can also be a factor. So in terms of lifestyle, then overweight and obesity, alcohol consumption, excessive alcohol consumption, and tobacco use. So these are the more common causes of or factors falling under environmental and lifestyle risk factors. So the exact cause of the colorectal cancer is difficult to identify exactly at the time of the diagnosis for a particular patient. So more commonly, as I said, sporadic is more common rather than hereditary, only 5 to 10%. And also more commonly, it's multifactorial, hindi lang isa, hindi lang tobacco use, but probably combination of tobacco use and overweight or alcohol consumption plus low fiber diet, no? Low fiber diet and low in fruits and vegetables. That is what is meant by multifactorial. Maraming factors that come into play, hindi lang isa. So, what are the symptoms and signs that will lead to suspicion of colorectal cancer? Many people with colorectal cancer experience no symptoms in the early stages of the disease kasi maliit pa at walang nararamdaman. Okay. When symptoms appear, they will likely vary, iba-iba, depending on the size of the cancer, the colorectal cancer, and also the location of the colorectal cancer. Common signs and symptoms will include the following. There will be a persistent, talagang hindi nawawala, palaging andyan. Okay, persistent change in bowel habits, which include diarrhea and constipation. Okay, hindi lang, most of the time it's constipation, but pwede ding magkaroon ng diarrhea. Okay, or a change in the consistency of the stool. Okay, or even the caliber of the stool, yung size of the stool. Okay. Rectal bleeding or blood in the stool is another symptom of possible colorectal cancer. Persistent abdominal discomfort such as cramps, gas, or pain, most likely because the tumor is now causing some degree of obstruction to the intestine. Yeah, may cramps, yeah. A feeling that the bowel does not empty completely is also another sign that will make us suspect possible colorectal cancer. But the more common ones will be a persistent change in bowel habit, rectal bleeding, medyo mas reliable ito. Okay. So once you see blood in the stools, okay, it's already a red flag that you have to do further investigation. How are colorectal cancers diagnosed, both clinically and paraclinically? When you say clinically, it's based on history and PE, and based on palpation, based on the interview of the symptoms. When you say paraclinically, it's when there are diagnostic tests done on top of the clinical exam. So a suspicion of a colorectal cancer diagnosis warrants initially a palpation of the abdomen to check if there is a mass there. If there's a mass, then that's a red flag for a possible colorectal cancer, especially if there are symptoms of rectal bleeding and also abdominal cramps. Okay? And then also what has to be done, also a rectal examination, okay, for any mass that may be palpable. So sometimes you may be able to palpate a mass in the anus, in the rectum. So the finger can reach about 3 or 4 inches from the anal verge. Kung minsan andyan ay bukol sa dulo, okay, makakapa natin. Subsequently, after the palpation of the abdomen and also of the rectum, a fecal occult test and a lower alimentary canal endoscopy, such as colonoscopy, in which a biopsy can also be done for any suspicious lesion. Okay. So other paraclinical diagnostic tests may be done as indicated, like CT scan, Okay. So, fecal occult blood test. This is a quite common diagnostic test, paraclinical diagnostic test being done. So it is used to find blood in the feces or stool. It tries to find blood in the stool that one cannot see. That's why it's called occult. Kung meron ng fresh blood, then you don't need to do this fecal occult blood. Kung wala kang nakikitang frank na blood, but you are suspecting, but baka meron, occult, you can do this fecal occult blood test. And then, why is this being done? Looking for occult blood, because blood in the stool may be a sign of colorectal cancer. Note here that this one, the FOBT, the fecal occult blood tests, are often used as a screening test for colorectal cancer. Usually, pag meron ng symptoms at meron ng nakapa, most likely meron ng colon cancer, obvious na, then we don't do the fecal occult blood test anymore. There are two types of fecal occult blood tests, the so-called guaiac-based FOBT and also the fecal immunochemical test. The difference between the two is that in the feet, you don't need to make dietary changes, such as you cannot eat meat. You cannot, because the meat can have blood that can give you a false positive reading. Okay. So in the feet, you don't need to make dietary changes, but in the guaiac test, you have to do this. You have to avoid some foods that might disturb the reading, the interpretation of the test. Okay, but in the feet, you may have to do avoid some certain medications like the NSAID, like mefenamic acid, okay, and also the blood thinning medications. So between the two, mas convenient yung fit because you don't have to make dietary changes. Up to the cost, baka mas mahal itong fit nito compared to the guaiac test. Okay. Now, the other paraclinical tests that are usually being done is the lower alimentary canal. When I say lower alimentary canal, it's the lower gastrointestinal tract. Okay. In contrast to the upper, when you say upper, it includes the stomach, the small intestine. But when you say lower, it's the colon and the rectum. Okay. So usually endoscopy will entail scope first. Okay. Scope looking at the inside of the colon, and a biopsy can be done as indicated. If there's a mass, diretso na, pwedeng kuha ng sample dun sa bukol. So that's what is meant by a biopsy. So there are different types of endoscopy depending on the length of the scope. Yung anoscope, hanggang dito lang sa baba. Okay. Hanggang sa anus and the rectum, makikita niya, mahikli lang yon. Okay. And then the proctoscope is longer, hanggang dito sa rectum, makikita yon. No? Okay. And then sigmoidoscopy, the scope is up to this far lang, this length. No? Okay. Now, colonoscopy, yung pinakamahaba, ito na yon, no? Umaabot dun sa cecum, okay? Or sometimes it can even go inside the distal part, the end part of the small intestine. So all these differ in terms of the length of the scope. Anoscope ang pinakamahikli, sa dulo lang makikita because mahikli siya. Colonoscopy, makikita mo yung buong length of the large intestine or the colon. So among the four that I mentioned, although meron pa yung mga instruments available, okay, yung apat na instruments, no? But what is most commonly done now is colonoscopy. Para isang examination na lang, tuloy-tuloy. No? Okay. So the scope is inserted through the puwet, to the anus, and then up it goes up to the ascending and cecum. And then there's a camera here that is attached to a monitor. So titingnan ng endoscopist yung anong makikita niya on the scope. Okay, if a endoscopy shows a mass here, ito parang there's a buccal here, it can do a biopsy can be done. Kukuha siya ng isang sample, no? Sometimes it's small polyp. No? The endoscopies can also remove it. No? That's another advantage of a colonoscopy. About the treatment modalities for colorectal cancer, the common treatment modalities will include surgery, chemotherapy, and radiotherapy. These are the most common. Okay. So it can be done singly, mag-isa lang, or in combination depending on the stage of the colorectal cancer. Example, surgery can be done for the early stage colorectal cancer. Kung meron na mga lymph nodes, then surgery and chemotherapy may have to be combined. And then in other cases, with far more advanced colorectal cancer, you may have to do chemotherapy first and radiotherapy before surgery. So a combination of the three. So when you do surgery, surgery means just removal, okay? Physical removal of the cancer as much as possible. When you say chemotherapy, we use drugs in the inject this vein to kill the cancer cells. Radiation usually uses a high-power energy beam such as X-rays and protons to kill cancer cells. Radiation can come also from a machine usually come from a machine outside the body. This is what we call external beam radiation. Yung parang X-ray, tinatapat sa body from the outside. Or sometimes it can be placed inside the body. That is what is called by brachytherapy. Among the common treatment modalities, surgery, chemotherapy, and radiotherapy, surgery is still the treatment of choice. Yan ang unang pipiliin kung kakayanin. Na? Okay. So it's usually the surgical resection is the treatment of choice, so which involves the removal of the cancer through surgery. It is performed to remove this cancer completely as much as possible and then reconstruct the bowel, if possible. Kung di kaya, then a colostomy will have to be done, or enterostomy. I'll show you the pictures of this later on. So ito, example will be a cancer in the transverse colon. So if surgery will be done, puputulin yang dito, okay? Dito, ayan, putol, no? Okay? So kasama yung cancer dito sa gitna, okay, usually with good margin, and then anastomose. When I say anastomose, iduduktong yung remaining ends, two ends, no? Yung walang cancer, no? Okay. So resection of the colon with anastomosis. Yan ang medical term, yung cut ends of the colon being joined is called anastomosis. Examples here will be kung yung cancer nasa right side of the colon, usually a right hemicolectomy, tinatanggal yan. Okay. So after matanggal yan, yung small intestine, kasi wala nang cecum dito, yung small intestine, i-anastomose dun sa remaining transverse colon. So para mabuo yung continuity of the passageway of the colon. Dito sa left hemicolectomy, kaliwa. Kung nasa descending colon siya, usually tanggalin kalahati dyan sa left side. Then after that, ito, iduduktong doon to reconstruct. Kung nasa sigmoid colon naman, dito, ipuputol ito, then i-reconstruct. Okay? So I want these are more examples of the cancer surgery for colon cancer, iba-iba depending on the location. So, at times, kung di na kayang i-reconstruct, okay, stoma, which is an artificial anus, when you say artificial anus, doon lalabas yung dumi. Instead of the puwet, lalabas yung dumi doon sa abdomen. No? So, that is what is called stomas. Okay, it may be created, no, kung di na kayang i-reconstruct. Example, here, andito yung colon, cancer, pinutol, baka hindi kayang ibalik, i-reconnect, then ilalabas itong end of the colon as a stoma. Here, it's called colostomy kasi colon, ano. Kung dito naman, example here, ileum ang nilabas, small intestine, that's what is called ileostomy. So the stomach can be temporary or permanent. No? Okay. So initially, kung temporary, initially, it will also affect the quality of life, but more so if it's permanent, then yung quality of life is more or less permanent. No? So one has just to adjust and live with it. No? Doon na siya dudumi forever. So which is more serious? Colon cancer or rectal cancer? The rectal cancer is usually more serious because it doesn't have a protective outer layer of serosa compared to the colon. Okay. And then which is more serious, right-sided or left-sided? Usually the right-sided is more serious because it's usually diagnosed at the later stage. Okay. So kung na-diagnose ng later stage, then the prognosis is poorer compared to the left side. Left side kasi ma-feel mo na kagad yung mga symptoms mas maaga. Dito sa right side, medyo mataas at usually distensible yung abdomen, yung intestine, kaya matagal yung magkakaroon ng symptoms yung pasyente. What is the prognosis? So, we usually talk of 5-year survival of cancers. Okay. Sa US, the 5-year survival is about 63%. This is the overall. Okay. Now, for those with localized stage, yung hindi pa nag-spread sa lymph nodes and surrounding areas, mataas, no? 91%. Yung 63 is the overall. Lahat, sama-sama natin lahat, no? Now, if the cancer has spread to the surrounding tissue, like the lymph nodes, then bumababa na yung 5-year survival rate to 72%. Okay. It will go down, the 5-year survival will go down to 15% kung yung colon cancer has spread to the distant parts of the body, like the liver, which is the most common site, yan ang pinaka-common, or other parts like the lungs. Okay. So this statistic shows the importance of early diagnosis and early treatment. So kung mahuli natin sa localized stage, then the 5-year survival will be 91%. If it has gone to the liver, then only 15% matitira. Sa Philippines naman, okay, so these are just the statistics that I was able to get. No? So in the 5-year survivals natin in the Philippines, at the moment, it's around 37% or 40% compared to the 63 of the foreign figures. No? Okay. Now, ito yung Z package na inintroduce ng PhilHealth to alleviate the problem of colorectal cancers in the Philippines. Kasi alam natin, maraming hindi nagpapa-opera because of financial difficulties. No? So after they have instituted the PhilHealth Z program, okay, in some years ago, but they made a report in 2018. Okay? That's about 5 years ago. Okay? So initially, yung estimate, as I said, ang estimate ng 5-year survival ng colon cancer is about 30%, 33%. No? And then with the C package, they made a study after implementation of the C program, naging tumaas na 74 to 70% during the 3-year lang ito, 3-year period. No? Okay. Kaya comparable sila. They have not reached a point that they have to study the 5-year survival. No? Okay. So there's an improvement with the Z package of the PhilHealth because nagagamot yung mga pasyente. No? So the C package of the PhilHealth will give you the following. Kung stage 1 to 2, low risk pa, then may 150,000 as a benefit. And then for stage 2, mga to 3, kung high risk na siya, more will be given, 300,000. No? Okay. And then they will, kung stage 1, kasama yung, this is for the rectum naman, ito sa itaas, colon, for the rectum, 150,000. Anyway, whatever it is, I won't go into the detail, you're going to get some financial assistance from the C package. So what are the screening strategies for colorectal cancers to promote early detection in the Philippines? Now, who should be subjected to the screening strategies based on the DOH program? Family history, when there's a family history, the screening should be done earlier rather than at 50. So at age 40, pwede lang umpisahan ng screening. For the others without family history, you can start at age 50 and above. And what are the screening tests that are being done? FIT, as I said, this is more convenient. Okay, FIT test. Then if the FIT test shows positive for occult blood, then a colonoscopy is usually being done. Okay. So the other screening strategy that must be present, aside from these two factors, this group recommendation is to advise all people to listen to your body at all times for possible colorectal cancer. That's the most important strategy, screening strategy to detect colorectal cancer early enough. So my advice on patients on colorectal cancers will be, one is to avoid the modifiable risk factors for colorectal cancer. When you say modifiable, yung kayang palitan, which includes the healthy lifestyle. Yung age, di mo mapapalitan, but the eating of healthy diet, no, pwedeng palitan. And unhealthy diet, pwedeng palitan. Then healthy diet can be maintained, can be done. Health, exercise, gano'n, kasama na doon, no? Listen to your body at all times for possible colorectal cancer. So we must know the signs and symptoms that may suggest the presence of CRC. Okay. So most important here will be the presence of blood, and then if you frequently feel that there is abdominal cramps, no, okay, matagal, 1 month, 2 months, then feeling of may mga change in bowel habits, no, so patingin ka na, okay? So consult early if with suspicious symptoms and signs of colorectal cancer. Then after the consult, have the early treatment if with established CRC. Okay, so face the reality that you have to undergo the treatment. Huwag aayaw if it's treatable. Okay. Then the other advice is to undergo cost-effective screening program for CRC as indicated. So I think that's the last slide for my pep talk proper. So let me do a summary and give you some of the takeaway. I have discussed all these items here. Okay, I won't read them anymore. And then takeaway in relation to patient empowerment, be always in touch with reliable medical information on colorectal cancers. Knowledge is power, it gives power. Use the 4 Ks of patient empowerment, such as kaalaman, kakayanan, karapatan, at kapangyarihan, to gain greater control over decisions in the prevention, recognition, and treatment of colorectal cancers in one's health management. So with that, I end my pep talk. I hope I have empowered you to have a basic understanding or better understanding of the colorectal cancer in your health management. Before we go to the QA, reminder again, take the OLETE. 50 OLETE certificates will entitle one to a voucher for a free ROJoson telemedical consultation. Then feedback, please type in your feedback in the chat box. Then let's now have a group picture taking again before we open the floor for open forum. Show your face. Okay. Okay, ready? Sino yung nag-scratch sa Samsung? 1, 1, 1, 2, 3. Okay, so the floor is now open for questions, suggestions, sharing, even consultation will do, but short consultations. Okay. Anything else? Anything that you want to ask? Okay, I see on the floor, Ben Sia. Ben is here. I'm happy that you're here, Ben.
Good afternoon po, Doc.
Ben Sia has reached 10 years as a colon cancer survivor. Okay. So would you like to share your experience? Kahit na briefly lang, para to
Yes.
inspire the other participants here.
Yeah. Good afternoon, everyone. I was diagnosed last 2012, so this is my 10th year. Thank you, Doc. First of all is hindi natin alam ano talaga buhay natin eh. So what I would say is we should have this kind of faith, no? Unang-una is the first and foremost is the prayers. The second is the lifestyle because in my early days from high school hanggang college is I grew up in the market. So alam natin yung mga kinakain doon sa kahirapan. So there was really a big change in the lifestyle, no? When I was diagnosed and after the operation. Plus nandyan si Mrs. na palaging nagagalit. Ano din, okay lang din yon kasi binabantayan din. Kasi minsan masarap din kasi ang bulalo eh. Yun. Tapos frequent prayers lang and then careful sa mga kinakain. And then after my operation in 2012, in 2013, sometime June, I started walking. And then I started fast breast walking. And sometime August, I bought a bicycle, mountain bike. And then from then on, araw-araw po nagbabike. In fact, there was on my highest high side of my cycling is darating ko po yung Lubali, galing dito sa Imos. I'm from Imos. Darating ko yung Batangas, yung ano to, yung isang bagong detachment dyan sa Ternate, no? Punta ng Tagaytay, bisikleta lang. And siyempre, hindi naman tayo talaga bumabata, padahan-dahan ng distance, no? And basta as long as everyday, kung pwede man lang, makapagpawis. And pinapawisan ako, normally maganda ang pawis ko pag nagbabike ako rather than walking or do jogging. Kasi minsan, sumasakit din ang tuhod ko sa jogging. While in the bicycle is, I can control the strength ng pagpedal ko. And then, yun lang, thank God na this is my, actually, a new life for me. Maraming salamat din kay Doc Joson. Nakadalawang ano pala ako kasi nagkaroon din ako ng addiction. So, ano lang, panalig lang, trust your doctor, trust God, and entrust everything. Yun lang po. Maraming salamat.
Thank you. Thank you, Ben. Okay. So, thank you for sharing para ma-inspire din other people. Any other people who want to share? Has anybody encountered other patients with colorectal cancer? Wala. Wala. Okay. So let's go back to Ben. Okay lang, Ben? Para ano? So, do you have a family history of colon cancer?
Wala po.
Wala. Okay. So most likely it's sporadic, no?
Yes.
Sporadic, no? Okay. And then kung sporadic siya, so ma-identify mo ba kung anong cause? Is it your lifestyle? Is it
I think it's the lifestyle, Doc, kasi yun nga, as I've said, I grew up sa market. At the time kasi, Doc, no, until my college days, meron kaming yung internal organs ng baka na pinakuluan. Sa
Okay.
amin kasi at that time, makabili lang kami ng kaunting laman noon. Tapos puso, I'm from Negros, puso or rice, no? And then maraming sabaw, solved na. Tapos toyo, most of the time toyo until na nagkaroon kami ng tindahan sa palengke. We sell toyo din, different kinds of mga toyo or bulad, no? We call
Okay.
that bulad.
Okay.
Diyan lumaki ako sa ganyan.
Okay. So yung mga kapatid mo, are they not in the same situation?
Hindi, Dok, kasi ano lang ako lang ang merong ganito
Hindi, yung yung pagkain mo, yung lifestyle mo,
Ay,
pareho lang, di ba?
on the few years, yes, pareho kami. Pero
Oh,
hindi sila, wala namang hindi gaya sa akin na napuruhan talaga ako ng cancer.
okay. So it's really hard to pinpoint, no, as the exact cause, no? Okay. We can just say most likely
Might be.
it's not
Most likely.
hereditary, it's something acquired, no? Okay. So, but even with acquired, we cannot really pinpoint, no? Okay. So, kung meron kang mga sisters then who develop colon cancer, no, we can call it familiar muna until we are able to identify yung gene, no?
Yes.
Okay. Kung 3, 4 nasa pamilya ninyo meron, most likely hereditary na yon, no? Okay. Kung 2 lang kayo, baka familiar pa rin yon, no? Okay. And then being in the family, kuminsan you are exposed to the same environment, di ba? Ganon. No?
Yes po.
So, pero kuminsan yung mga kapatid mo hindi tinamaan, ikaw lang tinamaan, di ba? Ganon, no? So it's really hard to pinpoint, no? So at the moment, just rely on yung mga recommendation on what to avoid na lang, di ba? That's the best way, just to avoid the risk factors, no? Okay.
Yes po.
No guarantee, but it could help, no? So it has been shown that probably 70 to 80% of people living a healthy lifestyle can avoid all these cancers, no? Not only colorectal cancers and other cancers, no? So we're not saying 100% guarantee with no cancer development, no? Okay. So just okay. Ano yung mga symptoms mo pala?
On the last bago ako na diagnose, Doc, is nahirapan akong dumumi. And then kung pag dumumi ako, parang kambing, pa kunti-kunti.
Okay, lumit na yung
Pahirap ng pahirap while palapit na ako doon sa sa time na operahan or yung malapit ang ma-diagnose, gano'n.
yeah.
Kaya yun, na ako ng internist.
Okay. So yung we call that change in the caliber of the stool, no? Yung kalibre lumiit, di ba? Parang kambing.
Yes. Opo.
Goat-like stools. Goat-like stools. Okay?
Yes.
So, lumiit because meron ng tumor na inoccupy na yung lumen, yung loob, no? Kaya lumiit na yung passageway, no? No? Okay. So pero yung symptoms na abdominal discomfort, meron na bandang huli.
Meron na.
So nung umpisa wala, di ba?
Nung umpisa wala.
Okay, progressive yan no? Okay. So yan ang i-watch out niyo. Walang dugo.
Wala naman.
Okay. So that's the first red flag for colorectal cancer, no? The second one, more common, is mga may blood, no? Blood sa stools, no? Okay. Okay. So yan ang just focus on those 2. Okay. Yung iba naman non-specific na yan, mga weight loss, no? Non-specific yan no? Okay. Okay. So then sige nga, i-narrate mo nga, nag-fecal test ka pa ba? Hindi na.
Hindi pa, Doc.
Hindi na, no? Nag-colonoscopy ka na, no? With your
magpa-schedule pa ako ulit ng colonoscopy po.
Hindi, we're just parang tinetrace ko lang para
Ah,
illustration. So
okay.
after nagpa-consult ka kay Dr. Uy, di ba? Mandy Uy.
Yes po. Opo,
So,
monthly.
so colonoscopy na kagad ginawa sa'yo.
Yes,
Okay.
colonoscopy at saka endoscopy.
Upper. When is it endoscopy? Upper.
Yes,
Okay. So,
upper. Dalawa na po.
dalawa, sinabay na niya, na? Okay. Pero, so colonoscopy, mas importante yon. So, may nakitang bukol. No? May biopsy ba bago kita na-operahan? May biopsy ba? Nakalimutan ko na.
Meron yon, Doc.
Okay.
Pero kita na, Doc, kasi ang butas daw is mga 50% na lang.
Okay. Okay. So, ayan. Pinapanarrate ko lang kay Ben para to illustrate what I discussed earlier. No? So, after that, we went for a surgery na. No?
Yes.
So, ano bang ginawa ko sa'yo? Nakalimutan ko. Basta pinutol ko yung bituka mo.
Yes, ako rin. Naalala ko rin yun.
And
Good
then,
thing naman, Doc, na yung pagputol, hindi na, ano to, ano yung bag? Ano yun?
colostomy.
Walang colostomy bag.
Ah,
Yan.
okay.
So, meron lang akong kunting, ano sa gilid, ano to, yung parang sa saranggula. Ano ba yun? Parang drain, yes. Yun lang yun.
Drain.
Opo.
Drain.
Parang ganon.
Yung drain para to drain out fluid as well as
Yes.
use as a signal kung may nag-leak, baka may mag-leak doon sa pagduktong anastomosis, no?
Okay.
Ganon. So wala naman, so good, no? Fortunately wala, and then fortunately wala kang stoma, wala kang colostomy, no? Okay.
Wala po.
So we were able to catch it at the earlier stage, no? Okay. So one worst scenario, you could end up with a colostomy. Pag
Yes.
advance na, hindi na kayang tanggalin, then kasi barado na yung bituka mo, then we have to divert na yung mga feces, yung mga tae mo, di ba?
Opo,
We have to create a permanent colostomy na, ganon. Okay. So that shows the importance of early diagnosis and treatment to avoid a colostomy as much as possible. Pero kung minalas ka, kung yung cancer mo nasa puwet, usually wala kang choice eh.
Okay.
Di ba? Kung nasa puwet na mismo, sa dulong-dulo na, kasi wala ka ng kasi puwet na tinatanggal mo eh, di ba? So mahirap na i-preserve yung puwet. So definitely you end up with a colostomy. Parang kapalit nun, artificial anus. Pag mas mataas, doon sa may rectum, descending colon, sigmoid, pwede pa. Mas maganda. Na? Okay. So, kadalasan, kung minsan, swerte-swertihan na yan kung saan nag-develop yung cancer, di ba? Kung ang cancer mo nag-develop sa puwet, then no choice but to do a colostomy. Tatanggalin buong puwet mo at ipo-colostomy ka. Na? Okay. 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 So after that, nag-chemo ka, di ba?
Yes po.
Bakit ka nagpa-chemo? May nodes pa tayo nakita?
Meron po, and then pumunta ako sa oncologist.
Yeah.
And then merong mga types of tests. And then we decided on the oral and IV na chemotherapy.
Okay. So, okay. So then after that, surveillance na. Tapos na.
Yes. Then another colonoscopy ulit.
So surveillance will be using colonoscopy na, no? Okay. And then 10 years na siya. Congratulations.
Yes.
10 years.
Thank you po.
Okay. Okay. Any questions from the others? Sharing? So who wants to talk? Gladys, would like to say something, Gladys, for your husband?
Yes, Doc.
I
was really very thankful. I'm very thankful for you, Doc, and the Lord for helping and helping Ben in his sickness, or minsan kasi sa tawag doon, katigasan ng ulo ng tao, minsan hindi maiwasan yung mga bawal na food. So after nung operation niya, minomonitor ko siya, sinasabihan ko na bawal yan sa kanya, and then minsan matigas ulo. So 'di ba recently nagkaroon na naman siya ng nagtatae na ganyan. So kinakabahan ako niyan, Dok, every time pag meron siyang nararamdaman. So sabi ko, nung matagal na siya hindi nakabisita sa'yo, Dok, mga how many years na, sabi ko, bisita ka kay Doc Roson. Kaso lang, di ba, pandemic at that time. Ngayong bumalik na ang economy, so ganun, sabi ko, try to visit again. Kung hindi siya nagkakaroon ng, tawag dito, nagkasakit recently, yeah, hindi talaga siya hindi maisipang bumisita sa'yo. So ako talaga ang nag-insist sa kanya. After na nagpa-check up siya doon sa Medicard, ganyan, and then due to diarrhea, ganyan, sabi ko, we really have to go to Dr. Roson again.
Okay.
So, para kumustahin yung health mo. So I was happy, Doc, na nandyan ka pa rin. Yeah,
Okay.
we really trusted you.
Okay.
Yan. Salamat, Doc.
Okay.
Yan lang po.
So, importante yung support, no, Ben? Okay.
Yeah.
And also, after an operation for cancer, yung tinatawag na health maintenance, no? Health maintenance.
Yeah.
So, number one, dalawang bagay yan. You continue your healthy lifestyle. Tama yung ginagawa mo, no?
Yeah.
Baka kasi we don't know. Ang theory natin, baka yung lumabas yung colorectal cancer mo during the first time, baka due to faulty lifestyle, di ba? Okay. So,
Yeah.
so tinanggal na yung cancer, pwedeng umulit yan because of unhealthy lifestyle ulit, di ba? Okay.
Correct.
And remember,
Yes.
yung colon mo, just one part of it natanggal lang, di ba? Meron ka pang colon, di ba? Sa itaas, sa baba, no? So pwedeng magkaroon ulit ng colon cancer doon sa ibang areas, no? So
Yeah.
so preventive measures, just to rely on healthy lifestyle and then just pray, no? Okay.
Yes.
The other thing that we have to do is surveillance. Yun nga, colonoscopy will be one of the main surveillance approach, no? Okay. Okay, thank you very much for sharing.
Thank you, Doc.
I hope you can inspire other people to do the same para, okay, for early diagnosis and treatment, na? Okay. So, wala nang tanong, wala nang I see a new face dito, if you don't mind. Bernie, I see a new face.
Good afternoon, Doc.
Bernie?
Yes. I'm Bernie Eliazar. Ano po, nahiya ako magtanong eh. Kaya lang tinawag niyo na ako eh. So I have to ask you na, 72, at 72 years old, luckily, wala naman akong ganyang problema. But I remember, nung kabataan ko po, nagkaroon ako ng mass sa dede. Does it mean anything na cystic ba ako or meron ka akong lahi? And am I disposed to this kind of CRC?
Sa breast? Sa breast?
What? No, ano po ba ako? Yung may chance ba na magkaroon din ako ng colon cancer?
Everybody, anong preliminary intro mo? Meron kang cyst?
Ano po, nung kabataan ko po nagkaroon ako ng cyst sa dede. Sa dede po.
Sa breast.
Oo.
Sa breast.
Sa breast, yes. Sa breast. Left and right.
Left and right. Okay.
Pero binayopsy po nun, wala naman pong malignancy.
Most likely, walang kinalaman. Ang tanong mo kung may mag-contribute dun sa CRC mo, most likely,
opo, baka magkaroon ako ng CRC.
Most likely, wala. Na? Of course, may mga isolated cases, di ba? Mga rare, tinatawag na rare na pwede, no? Pero
opo,
one of the male, hindi, no? Okay? So, at age 72 ka mo, you're not immune from any disease. That's number one. Okay?
opo.
Number two, you're not immune from colorectal cancer or any type of cancer. No? Okay. So, yung kaya that's why we just have to rely on healthy lifestyle and then just pray and hope na ang tama sa atin, most likely all of us will have a particular disease and probably die of it, di ba? Okay, just hope it's something that is not hindi siya masyadong masakit, bothersome, that will drain out your resources, no? Ganon. Na? Pray na lang, having an event.
Thank you.
Na? Okay.
Magdagdag pa ako, Doc.
Ano?
Pwede pa ako magtanong?
Pwede, oo, pwede ha.
Yung healthy, the healthy lifestyle, mahirap, madali yan. Lately lang, may naramdaman ako na kirot on the left side of my body, sa left side, sa bandang mababa. And na-realize ko, nagkaroon ng change sa bowel movement ko. And I was thinking, it has to do something with iniinom kong gamot. Because at 72, di ba, marami na akong ginagamot. One of them was calcium. Binigyan akong calcium. Tsaka yung pang-alis ng sakit sa tuhod and syempre sa high blood. Pero dati naman po, hindi ganun eh. Hindi nag-change ang bowel movement ko. And minsan, syempre, na-realize ko, I have not been eating gulay lately. So, kakain ako ng kangkong and it does something good. Ano yun?
Nawala yung
Opo, wala po yung kasi syempre sa bahay ko anong niluluto ko, gusto ng mga anak ko luluto ko. Then na-realize ko hindi na naman ako nakakain ng gulay. Then andyan na naman uli yung matigas na pagdumi.
Okay. So may constipation ka, gano'n?
Opo, once in a while.
Once in a while, okay lang yan. Lahat tayo magkakaroon ng constipation. Once in a while, especially when we eat something that is not conducive to our bowel movement, di ba? Kasi a lot of times we cannot really, hindi naman natin palaging nasasabi, pag itong kinain natin, pare-pareho, hindi tayo magkakaroon ng constipation, no? Kasi iba yung kinakain natin every day, di ba? Okay. So anyway, I think to answer your question, ito yung aking masasabi, no, to guide you how to manage all these symptoms that you're talking about, no. Number one, just stick to your healthy lifestyle, no, as much as possible. If you fail, get back to it, no. And then if you feel something, meron kang simptomas na pain sa likod ka mo, no. And you try to make a diagnosis out of it, na? Okay? Kung i-try, no? Try mo lang, ha? Okay? Kasi dito sa pep talk natin, no? If you want to attend more, sino nagturo sa iyo dito sa pep talk natin?
Si Chuchi Quevedo.
Okay, si Chuchi.
Kasama ko siya sa sinag.
Okay, sige. So yeah, okay. So try to attend so that you can learn something, how to manage, na? Okay. So yung going back, if you feel some symptoms, try to diagnose nga, na? Okay. Try to diagnose in terms of let's say back pain. Just try your best, ha? But if you attend this pep talk, baka you can get more mga tips on how to do it, na? But for the moment, if you have back pain, depende sa side, kung sa left side, right side, na? And then you try to feel, is it coming from the bone? Is it coming from the muscle? Na? Ganon. Na? Ikaw lang, just best effort lang, ha? Okay? And then input mo yung kung ano yung yung kasabay na symptoms, na? Yung sinasabi mo, ano ba yung kasabay nun? Yung constipation mo. Magkakaroon ka ng constipation, na? Okay.
Yes, sir.
You try to connect the two, baka combination yon, na? Okay. Okay. It could be separate, na? Baka constipation is another story, yung back pain baka another story, baka yung back pain mo ang back pain mo, number one, based on what you told me briefly, baka arthritis, di ba? Okay. Number two, baka you're taking calcium, no? baka meron kang urine stone, kidney stones, di ba? Ganon. Mga possible lang ito, na? Okay? And then yung constipation mo, you can say, ay baka tinatawag na functional constipation, baka hindi lang ako nakakain ng mga high fiber diet, na? That's one. Number two, baka possible na worst scenario, baka meron nagbabara na doon, na? Okay? Like CRC, ganon. So,
Yes.
you think about this, pero hindi mo ma-avoid naman to think about all these possibilities, no? But at that moment, you observe mo closely. You observe mo, no? Okay? Closely, 1 week, 2 weeks, no? Okay? So ang guide dyan, if it's something that goes away within 1 to 2 weeks, no? It's usually nothing to worry, no? Okay? And then, pag tumagal na 1 month, 2 months, 3 months, no? Then you have to see a doctor already. No? Okay?
Okay.
So yung you
Thank
observe
you.
mo muna sarili mo. Then try to adjust yung environment mo. Adjust the environment, no? Like kumakain ka ng mas maraming vegetables, no? See kung mawala. Kung nawala, baka yun na yun, no? Na baka due to lack of high fiber diet lang, ganon. Na? Okay?
Okay.
Yan lang may
Thank you.
tuturo ko ngayon sa iyo, no, yung mga principles of how to manage your health, na. Okay. Okay.
Yes.
Sige.
Salamat. Maraming salamat po, Doc.
Sige. You're welcome. Thank you for attending. We hope to see you and your other friends from Sinag Foundation to attend, na. Okay. Okay. So, any more question? Last call before we end? Meron? I bet may questions sa chat box.
Yeah, there is a question from, I think, si Naida Cabral ata ito. Hi, Doc. Ask ko lang po ang survival rate ng na-diagnose ng stage 4B yung best friend ko. Thanks po. Tama po ba decision na niya na hindi ipak-opera kahit anong treatment, chemo, on radiotherapy? Actually, I tried to convince her pa-check up sa'yo. Thank you po.
Anong stage, ano?
Stage 4B, Doc.
Of what? Stage 4B of?
Dati po, cervical, parang nagpina-bone scan siya kasi may pain na po siya sa balakang. Na-diagnose po siya ng stage 4B.
Of what? Of anong pinaka?
Sa bone. Sa bone po. Yayaya ko nga do magpa-check up sa inyo eh. Sabi ko para makaano ng opinion.
Okay, just like Bernie kanina may sinasabi akong diagnosis, no? Ganun, let's try to expand it, no? You start first with the diagnosis, no? Before I answer your questions, no? Or any question is any or anybody's question, no? Ang gagawin ko muna, ano ba yung diagnosis, no? Pag sinabi mong diagnose na 4B, then sabi mo sa bone, no? Number one, when say stage 4B, it implies may cancer siya, no? Okay, may cancer. But ang tanong ko ngayon, saan galing? Is it primarily sa bone or meron nag-spread sa bone?
Cervical siya, Doc eh.
Cervical
cancer. Parang ang alam niya po, may buko lang siya.
Cervical na uterus, cervical.
Opo. Hindi ko lang ma-Doc eh.
Okay.
Tapos yun nga po, may pain na siya, may discharge. Nagpa-check up po siya. Tapos yun nga, inano ng doktor na magpa-bone scan. Nakita nga po doon na
Okay.
stage.
So cervical ang cancer niya. Cervix, no? Okay. Uterine cancer. Kasi kanina akala ko bone na cervix dito sa leeg.
Hindi, kumalat na daw po eh.
Oo, kumalat na sa bone, no? Okay. From the palagi ko may iba ring meron pang ibang organs na tinamaan, hindi lang sa bone, di ba? Kung sa cervix, no? Okay. So ang anong tanong mo? Kung prognosis
tama lang po ba yung decision niya, Doc, na hindi na siya magpa-opera, magpa-chemo o kaya radiation?
Okay. Mahirap sagutin ng yung very specific na answer because it all depends on yung actual situation, no? Okay. Cervical cancer going to the bone. Okay. Kung means in terms of kasi when we treat mga cancer, we define it from the very start. Ano yung mga goal of treatment, no? Is it just for palliation or still aiming for cure, no? Okay. So at this stage, kung meron na sa bone, we don't aim for cure anymore, no? So we aim for palliation. Ibig sabihin, huwag lang siya mahirapan, makontrol lang, no? Para humaba konti ng buhay niya, no? But eventually the prognosis is very bad, no? Kasi kung 4 na kung 4, in general lahat ng cancer except for thyroid, no? Pag may 4 ka, pangit na, no? Sa thyroid cancer kung may 4 ka, maganda pa rin, no? Okay. But for the other types of cancer, pag may 4 ka na, stage 4 na, hindi na maganda, no? Okay. So in terms of decision making, kung anong gusto niya, no? So hindi ko masabi kung tama ang decision niya, no? Pero importante ma-coach siya kung she decide not to have the treatment, no? Basta she must be ready to accept it, no? To accept it, no? Ngayon. And then the family members should also be able to support her kung anong decision niya, no? Okay. So maraming factors that comes to play, no? But in general, pwedeng tama, na kasi poor ang prognosis, na. Okay. Okay.
Pilitin ko din magpa-check up sa inyo, Dok, para makaano ng opinion.
Yeah. Yeah, opinion, and then I do a lot of counseling also. Yung mga especially yung mga nasa end stage na. Importante kasi yung counseling eh, na. Okay.
Thank you po, Doc.
Okay. Any more? If there are no more questions, we'll call it a day. Wala na? Last call? Wala na? Okay. So next week, we might be talking on rabies. Rabies na lang muna. Ha? Rabies because it's rabies month based on DOH. No? Okay. So I'll be giving a talk on rabies. No? Okay? So kung wala nang tanong, we'll call it a day. I'd like to say thank you to everybody for attending. No? Okay. Bye-bye.
Thank you.
Thank you, Doc.
Thank you, Doc.
You're welcome.
Bye-bye, Doc.
Bye.
Thank you.